Good evening, everyone. This is Derek Alderson, President of the Royal College of Surgeons of England, with tonight's webinar to discuss some of the topical issues around the coronavirus outbreak. Tonight, we are going to be focused on many of the issues that specifically affect trainees. That's not to say that there are not other issues that we are perfectly willing to deal with in your questions, but we'd like to devote extra time this evening to some of the specifics that affect surgical training during this crisis period. Can we have the next slide, please? This is just an outline of some of the things that we've done so far and some of the areas that we've been involved in. I'm delighted this evening to be joined by Bill Allum. Many trainees in the United Kingdom know Bill. He's a member of our council and has a long and distinguished history. That's the nicest thing I think I've ever said about him, by the way.
All right, President.
We are old friends, as they say, and he has a long and distinguished interest in leading surgical training in the UK, and Bill is going to deal with many of the issues to begin with. Now, if we can just go to the next slide, please. These are probably the 5 areas where we've received most questions this evening, and what we're going to try and do is to just spend the next 10 minutes with Bill giving you some outline information on each of these broad domains in line with the questions that we received ahead of tonight's webinar. And at the end of that 15 minutes, we'll then have the questions that you've posed this evening, and we'll deal with those and 1 or 2 questions that we've received ahead of time that we feel that Bill maybe hasn't covered. So without further ado, let's just go to the next slide, please. We're going to begin by talking about recruitment and national selection, and this is an update on where we are now, and I'm going to hand over to Bill to just talk in a bit more detail about recruitment and national selection. Bill, over to you.
Thank you, President. Thank you, Derek. As Derek said, I've got a long background. Good evening, everybody, first of all. I hope you're all well and coping with its unprecedented circumstances we find ourselves in. Derek said I've got a background in training. For those that don't know, I used to be chair of the General Surgery SAC, subsequently director of the Intercollegiate Surgical Curriculum Programme, and was JCST chair, Joint Committee on Surgical Training, up until 2.5 years ago. I am on council and I'm the lead for the Improving Surgical Training project. As a result, I work a lot with both the Academy and the 4 statutory education bodies, as well as the GMC, on matters relating to training. Now, we are obviously in extremely difficult times with trying to maintain the usual processes to allow trainees to progress through their programme from the beginning right the way through to the CCT. The discussions that have been had over the series of issues we are going to address have been going on for some weeks with not only the statutory education bodies and the GMC, but also a lot of the discussions within JCST, led by my colleague, the current chair, Gareth Griffiths, and the SAC chairs. Now, the intention from the point of view of specialty recruitment is obviously acknowledging the crisis we are in, but wanting to maintain that the recruitment start dates continues as normal as it hopefully will be come August. All 4 statutory education bodies wish this to take place to make sure that trainees are appointed to appropriate programmes and can progress with that start date, and to go into both in terms of the early years for core trainees and also those going into higher training. Admittedly, there are some differences across the country because London tends to start in October. Now, the challenge, of course, is that we cannot use the standard approach for specialty recruitment. Core surgical recruitment has completed. There was preferencing being done before the start of the lockdown, and those of you in core training, you should, I hope, if you haven't got them already, be shortly have your posts confirmed for beginning of core training in the summer. Specialty recruitment would normally be taking place over the next month in most specialties. Those of you who've gone forward for cardiothoracic neurosurgery and OMFS will have completed the first phase, but it's those in the other specialties where there's going to be the change that have been proposed in agreement with the statutory education bodies. Obviously, we can't do face-to-face interviews, and the decision has been taken to use a self-assessment process, which is currently used in 5 of the specialties. It's not used in general surgery and vascular surgery, but in other specialties, the self-assessment process has been used as part of the scoring for the portfolio station in the recruitment process. So it's been decided that candidates will make a self-assessment using a specific pro forma to document their experience against a series of categories. This will then be scored, and that scoring will be used to calculate an appointable score, and those who are successfully scoring above the appointable score will be offered posts in the specialties to start either August or, as I say, October for London. This is obviously a complete change and a complete move away from what we've tended to do. In those specialties where self-assessment has been used, it has been used successfully, and there's been good correlation between the self-assessment score and the portfolio score used by the interviewers. In general surgery and vascular surgery, this is a new approach, but the pro forma is being very carefully put together. As I say, it's categorical, and it will be assessed by the interviewers. And in order to get some validity, it is intended to have an assessment of the scores, looking at the content of the self-assessment for 10% at the upper end of the appointable score range, 10% at the appointable score range, and 10% at the lower end, just to make sure that there is consistency in the scoring. Obviously, it is very much a probity issue if an individual does not give the truth about what they've achieved from the point of their self-assessment. Candidates who are successful and are offered a post will start as planned at ST3. It is recognised that there may well be some issues, and probably either just before or just after Christmas, it is intended to have an assessment of the type of progress that the individual is making to make sure that there are no problems. The assessment that's planned is not meant to be of a summative of nature, but very much formative, a little bit like reviewing the learning agreement, which will be taking place at the beginning of the appointment in August. So that at that time, any areas where there potentially are some gaps, they can be made up for during the rest of the academic year, with then going forward for the usual ARCP process, hopefully as planned in the summer of 2021. We all recognise that this is a complete change. We all recognise it has its limitations. But unfortunately, we are in extremely difficult circumstances. And as this has worked in other specialties, the statutory education bodies believe this is the most appropriate way in which recruitment can be undertaken to a point to specialty training. I'll stop there, Derek, if I may.
I mean, that's great, Bill, and clearly this is the issue that affects or worries our trainees more than any other, and that's why we probably will spend more time on this particular issue tonight than the other questions that were posed. If we can just go back to the other slides, please, that'll be fine. let's just let me pose the other questions to you, though, Bill, that are much, I suppose, shorter answers, easier things perhaps to answer. The issue of rotations and dates. I mean, obviously, it must have gone on the vast majority of people that the 1st of April date has gone. And that's not a rotation date. But maybe you could clarify for people the subsequent rotation dates in the summer, and maybe those people who are thinking of rotating into TIGs and things like that, which I understand are not to happen now.
As those of you in specialist training will be aware, those rotation dates the rotations that was planned for April the 1st, i.e. today, have been shelved for fairly obvious reasons. However, it is planned for the normal rotation dates to continue with the workforce, be it in the core or the higher areas of training, to take place as planned on August the 1st. This is to make sure there's maintenance of the workforce within all posts to have that continuity. Now, we do recognise, and I think this is something where the college has got a significant role, we may or may not be out of this by August, and an awful lot of folk will have been doing some additional work out with their training, and I suspect an awful lot will require some form of leave to recharge the batteries, and I think that's something we have to be very, very conscious of.
Absolutely.
So effectively, it should be as near business as usual as regards to the rotation dates. The TIG fellowships, however, have suffered because of the fact that they would normally occur during the summer in June, July. And the JCST has taken the decision that those entering TIGs or planned to enter TIGs in June will not do so, largely because the standard of the experience which they would be expecting to get in the TIG would not really be there.
Yeah.
Those coming off the TIGs would be returning back into programme as they would normally have done. There are some issues with regards to certification dates, and I would refer you to the detail in today's publication from JCST, which gives you all the details with regard to how certification dates may be affected for those planning to go into a TIG or for those coming off a TIG.
Yeah.
So can I just, thank you, Bill, can I just remind everyone that the JCST has produced some further guidance, and that is on the website, or will be on their website very shortly. So just to make sure everyone's pointed to that.
Yeah.
Can I just pick up while I've got the floor, so to speak, just a question that came in before the webinar, but about self-assessment. It's from Caitlin. She says, I applied for TNO Wales and Northern Ireland, which do not include self-assessment on application. Will they be utilising the same self-assessment as HEE?
As far as I'm aware, all 4 nations have signed up to the same process. And so on that basis, the answer to that question is yes.
Okay, let's move on and talk very briefly, Bill, about exams and progress on the basis of exams. Maybe you could highlight for people the difference in progression for those in run-through programs and what that means. I should preface that, of course, by reminding everybody that as things stand at the moment, all intercollegiate exams are suspended.
Yes, as Derek says, exams have been cancelled across all colleges for the obvious reasons. There's several issues around exams, and we had some questions last week and some others have come through already. And I think it's just breaking it down into the individual components. As I said earlier, core recruitment has completed. Now, for those who have been successful in getting a core post, they obviously will be going forward to take their MRCS in due course, as and when it restarts. Those who are proceeding on a run-through program, if they have not pass the exam because they have not been able to take it because the exam they were planning to take has been cancelled, as they will proceed as planned within the context of the ARCP process, and they will go into ST3, and it will be expected they will pass the exam before they can progress to ST4, and that does include the improving surgical training cohort. For those individuals who are progressing from core into higher, in other words, they are being recruited through the self-assessment process, they will of course already have passed MRCS, otherwise they would not have been long-listed into the recruitment process. As regards FRCS, these are obviously under slightly different rules and regulations from Joint Committee on Intercollegiate Exams, JCIE, and although there have been dates published on the calendar for JCIE, these obviously will be put on hold. Further details about the timing obviously will be on the JCI website, and I think it's a case of working out, looking at that once things seem to settle down as to when those can take place. But as you all appreciate, for most specialties that does not occur until you're into at least ST6.
Okay. The next area that we had a lot of questions about were about the nature of ARCPs and how progression will be determined on that basis.
The ARCP process is again changed because of the absence of face-to-face, but in fact it is proposed that the ARCP process of assessing the evidence from individual trainees' portfolios will go ahead as planned, which will be conducted by video or telephone conference according to the Gold Guide, the COPMED document, which gives you the rules and regulations for training, according to the Gold Guide requirements of the panel, which at a minimum includes the head of school, associate postgraduate dean and TPD, and an educational supervisor equivalent. So they will be able to review the portfolios as normal part of the ARCP process. Now, it's obviously recognised that with a lot of ARCP processes due later in the year, that there will be a significant amount of time when trainees will not have been experiencing training. This will be taken into consideration. We actually have a precedent because a couple of years ago there were issues around the winter pressures and trainees were not getting elective experience. And when the ARCP process was taking place, the vast majority of trainees were awarded an ARCP1, but there were some requirements when they went into the next post to set up in the learning agreement those areas of capability and competence that they had not achieved because of the downtime, partly then through winter pressures. And the same principle is being perceived to be applied from the COVID-19 crisis. So effectively, the ARCP process will go ahead as planned. There are obviously some scenarios within the ARCP process when it is appropriate to have face-to-face discussion, not only with regard to the next phase of training and the plans for the coming year, but also for those trainees who have not made the progress that's anticipated and how that can be corrected. Those conversations will be maintained as before, rather than face-to-face, will be done on a video or teleconference link.
Okay. So the only other area that people asked us about beforehand was this issue of working across disciplines, that is outside your usual day job. And I think that we've issued guidance on this subject before from the college. But in short, I suppose there are two scenarios. The first is where you are allocated duties in an area where you have worked previously and where you have previously demonstrated competence and where you personally still feel comfortable in assisting with the care of patients in that area. That's scenario number one, and I think that's fairly straightforward. Scenario number two, of course, is where you are asked to function in an area where you are unsure, or where, more importantly, you feel that you do not have competence and that you're not really capable of exercising appropriate care for the patients in that area. Should that be the case, the important thing is to ensure that there is some training offered to you before you take up such a responsibility, and the college is quite clear about that. If you still remain in doubt, then of course, trying to find out from senior personnel, your consultant, your educational supervisor, your postgraduate dean, if it's necessary to escalate things that far, should all be routes that you can take in order to assure yourself that you are not placing yourself or a patient in an adverse situation. So yes, we can understand the need at the moment for individuals to work in areas where they're not familiar, but please try and follow the safeguards that we've indicated before. We'll renew that information on our website to make sure that it appears more prominently, because this is probably going to be an issue for an increasing number of people in the coming weeks. Andrew,
if I may just add to that, it is particularly if you're going to work in an area with which you're not familiar, and particularly if it's a non-surgical one, it is expected that the postgraduate dean is fully aware of this, and certainly HEE, and I believe the other three nations will have been written to the Trust Directors of Medical Education to point this out very, very clearly, so that you are not put in a compromised situation way out of your comfort zone. Yeah.
No, absolutely. That's an important point. You shouldn't really be asked to go and function in a way that the postgraduate dean has not previously said would be acceptable with some training. Before we go out into the great blue yonder and find out exactly what we're being bombarded with this evening, Andrew, were there any specific questions that were on that list that we got beforehand that we've kind of ducked?
Yeah, no, there's a couple, Derek and Bill, that have come in that are sort of on this theme of taking time out, either because you're, lending your shoulder to in areas that you're not your core skill areas, or for other reasons. So here's a question from Hema, if I've got her name pronounced correctly. Trainees commonly take time out of training for numerous reasons, like research or pregnancy. However, such actions place them at a disadvantage to candidates who've recently completed a core training program. How and why has the SAC equated the years since core training to a fraction of the experience offered by recent graduates of the core training program?
If I get the gist of that right,
that way.
If I get the gist of that right, it's concerned that those who take a longer period of time before they go into specialty recruitment may be at a disadvantage from those coming straight out of core. In the existing situation, the additional period of time post qualification / registration is taken very carefully into consideration by the appointments committees to give appropriate allowance for the fact that time spent out of a longer time spent away from point of graduation has been spent constructively. And so there needs to be evidence that there has been something achieved in that time, which ensures, as near as can be, a level playing field between those who are some further years away from time of registration to those who come straight out of core training. So in other words, there is an allowance made for that additional time after qualification, taking into consideration what's been achieved. So research, other out-of-program activities, out-of-program training or out-of-program research will be given due credit, but it's got to be made sure that there is something been achieved rather than not doing very much.
Yeah. I might say just a little bit about out-of-program research, because it's quite a worrying situation that we're in there that's quite specific. Obviously, for individuals who are out doing research at the moment, their laboratory may be closed, or the research facility, whatever it is that you're doing, may just not be available to that person. And of course, the individual may well have gone back to supporting clinical colleagues in the clinical workplace. Now, that clinical activity can be recognised, but the other side of it is, of course, if you can't complete your research and complete the work that you hoped to perhaps contribute to a paper, to a higher degree, to a PhD, whatever it happens to be, that is going to be quite problematic. From the college point of view, for those of you who are fortunate enough to be holders of college research fellowships, we have made some arrangements to be able to support people's salaries in the way that we currently do for extended periods in order to take care of those. But I'm sorry to say that I cannot tell you what the arrangements are for those of you who are funded locally or funded by some other external body. This is a real issue. Obviously, there are lots of people involved in research at the moment up and down the country. It's not something that we're trying to ignore. We will address it as best as we can. I hope that other major funders take the same kind of sympathetic attitude that we are taking in the college, but I'm sorry that I can't promise that because it's outside my control.
If I can add into that, I'm aware anecdotally that quite a number of research fellows in and around London are actually being co-opted to literally staff the Excel Nightingale. I think it probably would be very helpful to us to understand if that's happened to you, so we get an idea of how many trainees, even trainees on program, because I'm aware this is a potential as well, that we know really how big that issue is, because I think without you telling us, we won't really know, and that's something I think we really do need to know about.
Yeah. Lucy, do we have a list of questions?
Okay. We have hundreds and hundreds of questions coming in, so I'm going to try my best. Some of the we've also got just over 400 people on the webinar, so, and some people are still coming in, so it may be the case that we are just re-answering questions that we talked about at the beginning. I even had someone saying, can you just go back to something? So we might be just re-asking questions that we've already talked about previously, but I just want to go through the questions. Okay, so can the portfolios not be marked locally? They're approximately 1 in 4 staff, either off or in self-isolation. I'm happy to spray my portfolio with the strongest disinfectant.
Go on, Bill.
I think I acknowledge that, but I think it is one of those things where, as you all know, portfolio assessment is a key component to the existing interview process, and there has to be the element of externality into the way in which portfolios are reviewed, and how the scoring with regard to self-assessment is done. And because the HEE through its local offices, London looks after general vascular and plastics, and Yorkshire looks after the others. They are the main hubs of where this will all be based, and will link into so that they're the national selection group to whom you can ask any specific questions. But equally, it does depend upon the externality with regard to the specialties, and particularly from the SAC's point of view. So I can understand the issue, but actually there has to be the externality to continue with the normal governance process with regard to the assessment.
Okay.
Thank you. How are we going to verify the scoring of portfolios?
As I say, in the specialties where this has already been done, I think that the respective SACs are very confident that there is good validity between the self-assessment and the portfolio score given at interview. In general and vascular surgery, There's only going to be a small number of people actually overlooking the whole process, so it's kept tight. And as I said in my initial introductory comments, the validity of the scoring process will be checked with random selection of those at the top of the assessment scoring, those in the middle around the appointable score cutoff, and those at the lower end, just to make sure there is some validity and no inconsistencies. Recognizing there are some limitations, but in a way, like the standard process, we have to use something with which we feel there's some reliability.
Okay, thank you. This is an interesting one. So how will we know if people are honest in their self-assessment? And then another question coming in behind that, is there an appeals process for concerns over the mark?
As regards the honesty, I think we have to rely on the fact that you are all professionals and probity is so crucial to what we do. And we know that if there is any breach of that, that is a GMC offence or reportable event. Appeals, there's always an appeals process. There's a standard appeals process that's in existence for both interviews, as there is in exams, as there is in ARCP. And so that process would still be in place, as I understand it. It's the standard normal HE processes that we have in place.
What about if there's lots of...
I'm sorry, I presume, Bill, that as well, this idea that there will be some new interim assessment, probably end of this year, early next year, should also provide some reassurance. I mean, it's presumably meant to pick up those individuals who are perhaps struggling at that stage, but of course it clearly would also pick up any individual who had made a deliberately false statement.
Absolutely. That process is under development. It will not be an interim ARCP because of the way in which ARCPs function, but it'll be very much as should be happening with regard to midway through any attachment during training, that there's a sit-down conversation with the clinicals, with the educational supervisor, plus or minus TPD, to make sure that the learning agreement targets that were set at the beginning are being met. And obviously, if they're not, that can be addressed in the next phase.
Yes, yes. Lucy.
A couple of people have asked this. What if there's too many applicants with the same score?
There is a process already in existence in those specialties which have used self-assessment, which has some weighting on certain components of the categories within the self-assessment. And it is anticipated that that should not create an issue with regard to large numbers being scored at the same level, because there should be ways of, as I say, weighting specific criteria. That is something I think is being looked at the moment as both general surgery and vascular surgeries put together their pro formas. But again, something that I suspect JCST will comment on in due course.
Okay, so what is the timeline for getting out the self-assessment, and when will jobs be offered?
I'm going to struggle on that one, I'm afraid. The processes for applications have obviously gone out because of the timing when interviews were meant to be worked through. But it is currently underway through what's called the medical dental recruitment selection process, which is an HE run process, which is looking at the ways in which the self-assessment, when they are circulated, are completed, then gathered together and then assessed. So all I can say is that this is something that's underway between JCST and HE at the moment. And I'm sure you'll be informed as soon as that has been resolved. But there's very active conversations between Gareth and MDRS.
Okay, thank you.
That's a question that we'll try and answer for you after the webinar, and we'll try and produce a published response to that specific issue by inquiry with and dialogue with HEE.
Thank you. So a couple of questions about the exam. What if the RCS Part B is not passed by the start of ST3 and the May diet's cancelled? And then another question about exams is how much advance notice will be given for the rescheduled examination dates?
I can answer the first one. Those individuals who are moving into ST3 who have not passed the exam, in other words, they are on a run-through program, will be allowed to sit Part B during ST3 year. They must have passed it before they're allowed to progress to ST4. As regards to the dates, I don't know. And I think that's something that the exam boards will be sorting out in due course. Or I suspect at the moment, it really would be a finger in the air, see which way the wind's blowing, because I think you cannot make any statement on that at the moment. But I think rest assured, they fully appreciate the commitment they have to get this underway. You could speculate they may be having to put more diets in, but it depends on the availability of examiners.
Okay,
I
thank
think
you.
we could say, in answer to the question about how much notice is, we'll give you as much notice as we reasonably can. We recognise that that's a major issue. Obviously, we don't know when we'll be able to switch the exams back on, so to speak. Certainly in English College here, we've got our exam team working quite hard on all of the possibilities in all of that. So we'll try and give you as much notice as we can.
Yeah, I mean, obviously, the longer that the crisis goes on and the less able we are to return to normality, the more things are being postponed and put off, the greater the catch-up exercise. So I think, we just have to be cognizant of that.
Okay, thank you. If we were meant to rotate into something specialised, such as PEDS in April, CT1, which we're not going to be doing now, is there any chance of ensuring a placement before applying for ST3?
So if the point of that is, I want to do my paediatric attachment, but I can't because of the crisis, I think that's something that would need to be discussed with the program director to see if the rotation could be modified to accommodate that. I don't think there's an alternative. We certainly wouldn't want to extend core training into CT2 into a longer period of time. But I'm afraid I think that's just one of the practical challenges that we have, where that opportunity may be a possibility at some time into CT2. And don't forget, the design of the curriculum is very much to allow development of a specialist interest in the 4-6 months, because that's the way the curriculum has been put together to enable that.
She was very pleased that we answered that question. That was Holly. So for those progressing into either CT or ST this August, will the goalpost for passing the MRCS prior to ST3 be adjusted for 2 years ahead?
I'm not sure I get the gist of that.
Yeah.
It is still expected, you see, to complete core training and have an ARCP to allow you to progress. In other words, on the run through, you have to have your MRCS. Although, sorry, start again. Under these circumstances, if you're going forward on a run through, you can do so, but get MRCS during ST3. I'm not quite sure about the 2-year interval. I don't quite get that one, I'm afraid.
Okay, should we pick that one up afterwards?
Yes.
I'm sorry, just on the subject of core surgical training, we did have a question come in from nursing before the webinar. Says, I'm due to start core surgical training from this October. This training seems to have been halted for other current trainees. Will this affect the intake of new surgical trainees starting later this year?
No, I don't think so. I mean, it's back to the point, as I say, to use the analogy of the winter pressures. If you have missed out on something because of the crisis, then your expected ARCP outcome will take that into consideration. so that if you're a CT1 and you're going to CT2, if there's some things missing, then the learning agreement should put those skills that you need to gain back into the program for CT2. So the intention, therefore, is that the same cohort will finish as planned on the 2-year basis, such that a new cohort will start CT1 in August.
Okay. A question from Charlotte here. As April rotations have been cancelled, I now only have 6 months of general surgery experience rather than the required 12 months by October 2020. Will I still be eligible to start ST3 in general surgery, or will I need to postpone until next year?
So I take it that you're moving from, so is that from a CT2 or ST2, Lucy? Did she say?
CT, I think. Or
so it's core going into surgical.
Into higher.
Higher.
Yeah. If you are appointed into national selection into the ST3, it's expected that you will have an ARCP1. So in other words, you've completed core as defined in the curriculum. And therefore, it should be such that you can progress even though you've missed out on the complete complement of the components of your 4 rotations in the 2 years of core training. I hope that answers it. Come back if we're not sure.
Okay. So the timeline for the GMC new changes to curriculum, are they on track?
This is something that I think that is still very much being discussed between JCST and the GMC. There are a lot of details to this to get the curricula in place, and I think this is something that we have to await to see how that evolves from the point of view of those discussions between GMC and JCST.
Like
so I think
that there'll be delays in all of these processes.
I suspect that's the case, but as I say, I think probably we're still waiting for approval from the GMC of the main curricula, and then there will need to be some review on how we implement it. So, I mean, logically, there's probably going to be a bit of a delay, but it depends how much that is. But as I say, it's still something that's under review, so we can't really say just yet.
Okay, Lucy.
Okay, sorry. Will CT2 on extension, will core training on extension, sorry, I'm gonna have to do this one, doesn't make sense. So it says here, it is unclear and discriminatory on people with more experience.
So I take it that is the concern that we talked about earlier, whereby there's a perception that those who spent more time post-registration, be it in training or non-training posts, are at risk of being discriminated against when it comes to comparison with those coming out of core. The selection process has always had this as an issue, and has taken it into consideration, ensuring that what has been achieved during those additional years is of some substance and consequence and of benefit to the development of the individual, such that they are not disadvantaged when compared to someone who's come straight out of core with lesser experience.
Okay, so just to clarify, can I be a registrar in general surgery with only 6 months of experience?
If you've completed core, and you have been successful in your application to go into general surgery ST3, in other words, you've been successfully appointed through the national selection process and you have an ARCP1 at the end of core, then you can progress. Now, if you have less experience because of what's happening now, then that will be taken into consideration when you set up your learning agreement, when you go into your new rotation, or your new post, as it were, the training program you're going to go into for general surgery. So you would start, and as I say, having set up the learning agreement, that will be carefully reviewed, probably, if it's an August start, around about just before, just after Christmas, to make sure you're on target. And if not, then appropriate measures to make sure you can catch up or to gain those skills that you may not have had are included. But I would hope that the learning agreement when you start program in summer will be extremely carefully put together with good and definitely achievable targets.
Okay. Will we have the chance to update our self-assessments to include all the additional points we would have gained at the face-to-face portfolio assessment in April?
On the base, well, it depends what specialty you're going in for, you see, because the pro form, as I understand it, for general and vascular surgery, and this is something I'm talking slightly at arm's length, because my understanding is that the respective SACs are putting this together so that you will have a brand new pro forma to complete. So that's in the pipeline, as it were. However, if you're going into one of those specialties that have self-assessment,
He's T&O, sorry, T&O.
Well, on the basis, as I understand it, they have already been submitted, then I don't think you would be able to, but that's something I think would need to be clarified.
Okay, thank you. Will all applications for specialty, oh, sorry, it's going so quickly, will all applications for specialty training validated after self-assessment or only a random 30%?
Say it again, Lucy, sorry.
Will all applications for specialty training validated after self-assessment or only a random 30%?
This is just the random ones to make sure that there appears to be validity in the way in which the scoring's been put together on the self-assessment. So as I say, it's like any sort of random assessment of any scoring process. You look at the top end, you look at the middle end, you look at the bottom end, just to make sure there's not huge variation.
Okay, thank you. Research has shown that self-assessment is biased towards favouring male candidates. How will you overcome this?
Very difficult. We know this, and it's something that's come through from conversations across all specialties. And indeed, the chairman of the Academy of the Medical Oncologists, Professor Carrie McEwen, raised this as an issue. And I think it's very difficult for us to make any comment about that to try and get over it. I think it's one of those things we are unfortunately unable to modify.
Okay, will COVID-19 periods say, for example, April to August to be included in training, to say that my CCT date remains the same, but only to be pushed back, as I won't be doing the operating in the next 3 months, and I'm a mid-level registrar?
I think once, when we eventually come out of this, then in the middle years, and on the basis we will then move in due course into the new curriculum, we are much more going away from indicative years, but into a competence-based program. So if you've missed out for 3 or 4 months now, it's entirely probable that you'll be able to gain that as you move through the latter years of your training program. So I'd be quite optimistic that that would be something that could be taken care of, such that by the time you get further on in program, that you've actually made up for whatever you may have lost during this time. As I say, it's the same as what we had to cope with the winter pressures, when particularly in T&O, for example, there was an awful lot of elective joint replacement surgery going on, which trainees were not getting to do.
Okay, thank you. I'm a CT2 in London, so my core training should finish in October. Can I take up an ST3 position outside of London starting in August?
If you are appointed through national selection into program, and you have this is a difficult one. I know it's always been this issue between the start dates between October and in London and August elsewhere. As long as you have met the requirements to show you've completed your core training, which is an ARCP, and I know the ARCPs are often done later in September, then there should be no reason why you can't. But I think that's something that needs to be determined in discussion with the training program director and the postgraduate dean. And I think it would be something that would be clarified pending the outcome of the selection process. So I know I've waffled that one because I'm not quite sure exactly what the answer is, but I think it's something that should be addressed. If you're successful in the recruitment process, then it should be something that's addressed with the TPD into program that you're going to join.
Okay, the ST3 the ST3 applications has points for rotating through other specialties 4-month blocks. Will ST3 applicants next year be penalised for not having these due to moving jobs to support COVID-related pressures?
No, there should be no penalty for having to do what we're doing as an extra to keep the health service going in this crisis. The intention of it from the HE perspective is that trainee progress should not be impaired with the current problems we're facing. As I say, there will be opportunities to make up what may be missing or you've not achieved because of working in a different environment.
Okay, thank you. In ENT ST3 applications, we have until the interview date to gain further self-assessment points. The initial ENT assessment stated very clearly that it was preliminary scored, as we still have weeks to gain further points and evidence that's in the portfolio amending the self-assessment. How can this be addressed?
I'm afraid I can't answer that. I don't know. And I think that's something to go back to JCST and probably it's Yorkshire and Humber, the lead let to be for selection into ENT, and I think that's something that should be clarified there. I'm sorry, I can't answer that.
Okay, thank you. So there's a question.
I think is listening into the webinar. So sorry for JCST questions of that nature. I'm sure Gareth will be taking detailed notes and will help us get some answers to those.
I think yes, absolutely. He will pick up with the SACs, I'm sure, if there's any specific specialty areas that I can't answer, which is a lot of them, I'm afraid now.
Okay. Can you, I mean, I'm not sure if you know the answer to this one, we can try. Can you also please confirm roughly how many training numbers there are nationally for general and vascular surgery this year?
Can't tell you, sorry. That's something that gets sorted out with the SACs and HEE.
Okay, thank you. Can I apply for a fellowship or an Opie towards the end of this year, or have I to remain in the training programme?
As far as I'm aware, any of those sorts of activities are still on target. In other words, if you wish to do that, entirely something you discuss with your TPD to see where that fits in the trajectory of your training program to make sure you've achieved all what you need to achieve to date. And I can't see a reason why you can't continue as we would normally do to get the out of program experience training of what you wish to do.
Okay.
I suppose one thing on that subject that's worth maybe just saying that one imagines that start dates for out of program experience might well have to be deferred depending where we are in the crisis. In other words, the usual processes by which people go into research based on a certain project and a start date that's been determined locally, you know, those dates might have to be pushed back.
Okay.
Yes, Lucy.
I'm applying for ENT ST3. The self-assessment is largely academic. What evidence do you have that the portfolio score alone is a good indicator of an overall score?
All I can say is what I said earlier is from the individual SACs where they've used self-assessment, they've found it is a very good representation of the portfolio score awarded by the interviewers.
If we can prove that we have used our time out undertaking research, then how can we prove this? And would you consider removing the division of marks associated with time out in trauma and orthopedics?
There's two issues there. I'm assuming that time out is for the research process or research experience. Yeah, there are differences across the curriculum. It's a while since I looked at this, but I have a feeling research is within the TNO curriculum. So evidence that you've done research should be part and parcel of the portfolio. When it comes to, I don't know the content of the pro forma for TNO's self-assessment. there will, of course, I'm assuming some be input from educational research supervisors to back up any statements that are made. But I think that's something that, again, I'm not best placed to answer.
Okay, thank you.
Lucy, do we have any general questions this evening from the non-trainees in the audience, I suppose?
There's a question, excuse me, that came in, Derek, just before the webinar about visas. This is from Kuram. He is a trainee. He's on a 2-year fellowship with a tier 5 visa due to finish in August. We know that the government announced yesterday that there's a 1-year extension. The question is, does it only affect trust grade doctors or tier 2, tier 5 visas in their entirety? I think the answer to that, Kuram, is the latter, that it includes all tier 2s and tier 5s, but we will confirm that for you.
Yeah.
Okay, so there was a question around testing and PPE, Derek, that we had that came through at the beginning of the webinar. Is that 2 areas you just want to give an update on?
Yes, so that's useful. Public Health England today have finalised their new document describing PPE recommendations for just about every environment, and certainly just about every type of encounter that can exist in a hospital or adjacent to a hospital. It's still the case that they would wish to see this as a kind of living document, and that it might be subject to further revision as time goes by. It is supported, I understand, by the WHO, and it's important that perhaps everyone should understand that. It does make quite clear recommendations about levels of protection that you should observe in different clinical situations at the workplace. And when you read it, you may believe that it reflects the ability of the NHS supplies, as it were, to deliver that protection to your hospital and to the environments in which you work. There is, as you all know, an opportunity for you to highlight where you might believe the protective equipment that you're being offered is inadequate. And Public Health England acknowledge that as well. So really, we should have better supplies. We should have more of the right equipment in the right place. The document is trying to take care of that as best as possible. And we're being asked essentially to follow that new guidance very closely and hopefully to get feedback very rapidly to indicate that people are not being unnecessarily exposed to hazard in the workplace. It has been agreed by the Academy of all the Medical Royal Colleges to support this, and guidance produced by individual colleges, associations will over the next few days be brought into line with that. They'll be modified so that they should be entirely congruent guidelines between those issued to you perhaps by a professional body and those that have been issued nationally by PHE. Testing, as you know, is now starting for healthcare workers. You probably have all read about the issues about why it is not accelerating at the rate that you might hope for. This largely reflects issues around supply of reagent, I understand, and there's obviously time it takes for new labs to come on stream as laboratory personnel are retrained to be able to do more tests. So there's still a strong expectation that the number of tests that are available to us will increase substantially as we approach the infection peak in many parts of the country. But just how the process will be rolled out to healthcare workers and healthcare staff still needs to be kind of clarified. Okay. Well, I can't hear, unfortunately.
Yeah, no, Lucy, we can't hear you.
Apologies, sorry. So there's a few more that have just come through. Would there be any additional MRCS exam dates, or is there a possibility for this to be completed online?
We'll look at all the options that we can, both in terms of number of diets and in terms of how it's done. You'll appreciate that we can't, you know, what we mustn't do is change the standards, so to speak. So the likelihood is in the short term it will be done in the way that it's done at the moment, but we'll certainly try and put more diets in place. We are looking at the 4 colleges ultimately at bringing in computer-based testing for Part A, but I think that's a little way off yet.
Another question's come through around kind of mandatory courses such as CRISP, because a lot of the courses have been cancelled, and what's the implications of that with regards to completion of ST3?
Courses are perceived by the GMC to be a key component of learning rather than being mandatory. The only mandated course is actually ATLS and APLS because they've been validated. And so, yes, we'll recommend that all of these courses should be completed at different phases of training, but they're not absolute requirements because they're not mandated in a curriculum. However, I think it's entirely appropriate if you've not, or your course has been cancelled, then it would be, as far as I'm aware, there's reimbursement. I'm looking at Andrew. Reimbursement for the course fee so that you can reapply to get on a course at a later date when things have settled down.
Yeah, we'll either book you onto a future course, or if you need a refund, we'll obviously provide that. Just to point again at one of the things that Derek mentioned, and I think it's on the slide on the information hub, that we have made we are in the process of making the education materials to CRISP and START available online, so you can pick up those modules. They're being released over a course of time, and they're available for you obviously at no charge. So I realise that's not the same as doing the course, but there are some handbook materials that you can access.
Okay, so a couple of people have asked about how they document their training if they've been moved. So I've been moved to support the medical team and on-call medical rota. How should I document this in my ISCP? Obviously, I'm no longer doing my urology placement.
I think that I'm assuming it's a core trainee statement.
Yeah, DT1.
The recommendation is very much that you will be practicing professionally. And although you may not be gaining specialty specific skills, you'll be developing significant other skills from a professional point of view. And I would urge you to document what you're actually doing, be it team working, be it undertaking roles that you hadn't anticipated, because you are still developing professionally, and those skills that you will gain during this very, very difficult period, I suspect will be extremely valuable in other assets which you can apply as you develop your career. So the recommendation is very much record what you get up to, although it doesn't quite fit with the exact alignment of the ISCP portfolio, because it will be something that you can reflect upon, and you can discuss with your educational supervisor when you go forward for your next interim discussion. And as far as I'm concerned, I think this will be extremely valid experience. And indeed, these are key components of the generic professional capabilities which underpin the new design of future curricula. So I'd encourage you to record it in a way, recognising it doesn't quite fit with the standard workplace-based assessment process.
Okay, thank you. And with regards to indemnity, do we need to get indemnity to cover other areas other than surgery?
Because you have been seconded through postgraduate deans, your indemnity is maintained.
Okay, thank you. Is time on a formal ITU rotation after this crisis likely to become a compulsory component of core surgical training across the UK?
Don't know. There's potential on all things there. I know it's done with some rotation, yes, but it won't be. This would not generate a compulsory component.
Okay.
Wouldn't it be a good idea?
Indeed.
If for those of you who are on the call, undoubtedly very few of you are as ancient as myself, or even as ancient as Mr. Allum. But within the context of what used to be called SHO training, or let's just call it core training, intensive care training was very popular in surgical training, albeit 40 years ago, and gradually was dropped. I think for those of us who had the fortune to spend time in intensive care units, it was incredibly valuable, and I think there are lots of things that people would probably say, you know, that they would benefit from exposure to certain topics. Intensive care would certainly be one that I think would be very attractive to many surgical trainees.
Indeed, in many of the core rotations, it is an option because it was perceived to be a key component, because it allows you to meet an awful lot of the core competencies as defined in the curriculum.
Yeah.
Another question has come in. I don't think you'll be able to answer this at this point. Do you think there would be any additional FRCS clinicals before November diet?
Not something I think you can answer, and I suspect no. JCIE functions.
We can't answer that in an absolute sense, but I think at this late stage in the year, with all of the pressures that are upon us, I think it's unlikely, but we will always keep it under review. We appreciate that there is a backlog. We know that we have to deal with that backlog, but you've got to remember too, we have to have examiners as well as candidates, and the surgical workforce is going to be tired when we get to the end of this process now, when we come out of this crisis. We're all going to need a holiday, and you know, so there's a lot of things that could turn out to be the rate limiting factor about when we're able to restart exams and how many extra exams we're able to put in over the months as we come out of the crisis.
Okay. So there's a question that's come up a few times with regards, I don't think anyone on the panel necessarily will be able to answer. Might have to come back with regard to the MFDS result put on hold, the Part B. I don't know if anyone on the panel knows about those being put on hold and be taken off.
I couldn't answer specifically in detail to it, but my understanding is that the same applies, that the exams are all postponed at the moment. I've not heard to the contrary from the dental faculty that they are intending to progress examinations at this time.
Okay.
Yes, we've certainly cancelled the exams from the FDS in the English College.
Yeah.
Okay. Sorry, just to it's the results. Apparently the results for the MS hold something that we're going to have.
We might have to come back to you on that one. Yeah.
Yeah. About we can't add on to at this point diet for the MRS Part B. Other saying cow of questions we just can't answer at this point.
You're breaking up a bit.
Lucy, we are not able to hear you ask the questions at all.
Time say should be well to an end.
Well,
Hearing you, Lucy, but I know we've run a bit over time, and I think it's been important to do that. But I suspect everybody's got stuff they want to do, even if it's a bit of a break after, or even in the middle of a long working shift.
yeah.
Can I just make a comment that one of the things that we have been talking about is we're very conscious of coming back into training in the autumn, and it will be different. It will be new experience, and we're going to need a lot of support. And I think it's something I would personally see if we can try and develop from the college, to have on a regional basis some ways in which we can support the trainees, be they in core or be they in early years of higher training. So there's an appreciation you've got, there's people to ask questions of, rather than being left on your own in a new world. Because I think things will be different, and there is structure through the regional processes in the college that I hope we could try and develop. I don't know what you think, Derek.
No, absolutely. And I think that, you know, there are things that might be quite different when we come out of the crisis and we're able to step back a little bit and think around some of the things that have happened that we've adapted to under adverse circumstances that could be incorporated a little bit more into our routine practice and become part of our training. For instance, perhaps it's the case that the population will be more willing to have telephone consultations for surgical problems, something that is not widely practiced before the crisis, but increasingly is something that we're able to make use of. People might become more adjusted to that. The fact that people have not been attending emergency departments with relatively simple complaints in recent weeks might alter societal attitudes about piling into the emergency department, the delays that occur there, and the knock-on effect that that has for surgical patients. So, you know, the whole way in which we are able to conduct surgical practice, and by extension, how we are able to train people, might be somewhat different when we come out of this crisis. So the college has to try its best to see where we can make useful changes that will enhance your training and not make it detrimental as we go forward. I feel that I've almost had the last word there. I'm not sure if Andrew or Bill wants to say anything else. If not, I'll thank you all for your attendance. I hope that we did manage to answer or deal with most of the points that you raised in your questions. We'll be looking at the long list that we've received during the evening, and we'll try and deal with those with written responses. And next week, we'll have another topic to focus on.
Yes, we've got one next week for our dental members.
Good enough. I'll be off the hook. Anyway, in my dreams. Okay, keep up the good work. Stay safe. Please remember to keep yourself adequately protected. Please, when you've been in a clinical encounter, and if you're just not sure, spend a minute or two to think about it afterwards. What did you think the level of risk was that you were exposed to? Do you think that it's safe for you to continue seeing patients after that type of encounter? Please read the new NHS guidance on PPE, and best of luck. Work hard, but don't exhaust yourself. Thank you.
Thank you.
Thank you.
Thank you.